I love coagulation disorders. I mean, I don't love having them, but the reason that I love them and they're so easy for us to go through is that they're so logical and they form patterns that are easy to recognize, and you can predict the answers because it's a system that's very, very well thought out and logical. And this is one of the only physical findings we can have in our section, which is petechiae and purpura. And what's the only difference between petechiae and purpura? Is size. Right now I'm just a little petechiae, but someday when I grow up I'll be a big purpura! And it's just size, petechiae and purpura. When you see petechiae and purpura, that is signs of which type of coagulation problem. Clotting factor deficiency or platelet problems. This is a sign of platelet dysfunction or clotting factor dysfunction. And when you see petechiae and purpura, it's a sign of platelet dysfunction. Petechiae. Factor type bleeding is deep into joints and muscles and joints. It's deep. It's into joints and muscles and joints. When you see factor bleeding, it's like hemophilia, delayed bleeding in a male joint. So the platelets, wait a second, Conrad, you just said petechiae and purpura are a platelet problem. That's a normal platelet count. Normal platelet count's like 150 to 350. That's a right in the middle normal platelet count. That's the whole point. This is a platelet type of bleeding with a normal platelet count. A platelet type of bleeding with a normal platelet count. It's a platelet type of bleeding with a normal platelet count. Von Willebrand's disease. The other thing about von Willebrand's disease, von Willebrand's factor 8 antigen, and the words von Willebrand factor and factor 8 antigen are interchangeable. The von Willebrand's factor 8 antigen travels bound to factor 8 coagulant, and that's why half of people who have von Willebrand's disease have an elevated PTT. A platelet type of bleeding with a normal platelet count, von Willebrand's disease. So the first thing when you're looking at bleeding questions is to decide what's the type of bleeding. So the petechiae and the purpura by definition mean platelet bleeding, and so does epistaxis. Epistaxis, platelet, gingiva, gums, skin. Now bowel and brain and bowel can be either one. Bowel and brain and bowel can be either platelet type bleeding or clotting factor bleeding, but skin and epistaxis and gingiva is platelet type of bleeding. What about the vagina? Is the vagina a deep or a superficial structure? The vagina hematologically is superficial. Petechiae, purpura. What's the difference between purpura and ecchymosis? Ecchymosis is even bigger. What's the difference between saying a bruise and saying an ecchymosis? Nothing. Going to medical school. The most accurate test. Bleeding time is not the most accurate for anything. Bleeding time is a fantastic medieval test. You cut people with razor blades and time how long it takes them to stop bleeding. Von Willebrand's factor level and an aristoseton cofactor is the most accurate test. It is the most accurate test. Von Willebrand factor antigen level and ristocetin. Ristocetin is a functional test. Ristocetin is a test that says, okay, if you have normal levels of von Willebrand factor, does it work? Because von Willebrand deficiency, von Willebrand's disease can be either of two types. It can either be a total deficient amount of von Willebrand factor or a deficient function. Ristocetin testing tests the function. Ristocetin is a failed antibiotic. Ristocetin was a type of a tetracycline type of antibiotic that failed because it caused a problem with your platelets. There is nothing to be seen on a bone marrow biopsy with von Willebrand's disease. Antiplatelet antibodies are never correct for anything because antiplatelet antibodies are too nonspecific. Antiplatelet antibodies are not right in any disease at any time because antiplatelet antibodies can be present in 20 to 30% of the general population right now, even without any disorder. The last one there, mixing study. When is a mixing study the answer? Mixing study is the answer when you have an elevated PTT or PT and you want to see, is it a deficiency of a clotting factor or is there an antibody inhibitor? If you mix up a patient's plasma in a 50-50 mix with normal serum and plasma, Any deficiency should correct to normal. A mixing study is how you tell a deficiency versus an inhibitor. If you have a deficiency and you mix it up 50-50, the PTT will come to normal. This is petechiae and purpura. And petechiae and purpura are the same thing, indicating platelet dysfunction, just a difference in size. Von Willebrand's disease, a platelet type of bleeding with a normal platelet count. The best initial therapy was desmopressin. The best initial therapy is desmopressin. The best initial therapy was and is desmopressin for von Willebrand's disease and for mild hemophilia. Desmopressin causes the release of subendothelial stores of factor VIII and von Willebrand's factor. If you persist in bleeding after the desmopressin, you'll give factor VIII. Now, the same answers are for mild hemophilia as well. I got mild hemophilia. I give desmopressin to release the subendothelial stores of factor VIII and von Willebrand's factor. Mild hemophilia, same thing. Steroids don't help with von Willebrand's disease at all, ever. Plasmapheresis doesn't help with von Willebrand's disease. Plasmapheresis doesn't help with ITP. Cryoprecipitate is clotting factors. Cryoprecipitate is basically fibrinogen. Cryoprecipitate is never first for anything. Cryoprecipitate is given when you have a person who's got DIC and they're consuming all their platelets, they're consuming all their platelets and fibrinogen. They're using all their platelets, the fibrinogen, and you give them fresh frozen plasma and they're still having bleeding. Cryoprecipitate is what you'd add as a second or third thing to try to get the bleeding to stop if you had DIC. Fresh frozen plasma is a good initial therapy for when you're vitamin K deficient and you want to correct it right away, faster than vitamin K. Fresh frozen plasma is for the rare person with factor XI deficiency who's bleeding. Vitamin K is when people have vitamin K deficiency. What about this last one? Epsilon aminocaproic acid. And also vitamin K is also used when you sometimes, in some people, both of these are also used in some people with warfarin overdoses. Epsilon aminocaproic acid, sometimes called Amicar. Epsilon aminocaproic acid inhibits the lysis of fibrin. It blocks plasmin in a way. Plasmin chops up fibrin. And epsilon aminocaproic acid stops the destruction of fibrin. So epsilon aminocaproic acid can help you stop bleeding if you have certain platelet problems like Glanzmann's thrombasthenia and Bernard-Soulier syndrome. What is this therapy? Okay, what if this therapy doesn't work? If the desmopressin does not work, in other words, you have von Willebrand's disease and you gave desmopressin, DDAVP. It releases the subendothelial stores of factor VIII and von Willebrand's factor, and some people are controlled and some people are not. And the way that you fix it now is you give them factor VIII. You give them desmopressin, which causes the release of subendothelial stores of factor VIII and von Willebrand's factor. And if they continue to bleed, you replace factor VIII. Because remember, factor VIII antigen, the von Willebrand's factor, travels with the factor VIII coagulant. So if you give the factor VIII, it will also have the von Willebrand factor in it. Fresh frozen plasma and vitamin K can be used for people, and some people have warfarin overdose, be used in vitamin K deficiency, and they can be used, fresh frozen plasma, liver disease bleeding, factor XI deficiency. Cryoprecipitate is never first for anything. It's basically pooled products, pooled clotting factors, especially fibrinogen. This hormone, did you know that estrogen makes your platelets perky? Yeah, estrogen makes your platelets perky. Estrogen makes your platelets perky? Yes, estrogen makes your platelets perky. We think that this is part of the reason why women are more hypercoagulable, because estrogen helps the platelets who have more effect of the von Willebrand, maybe why women get more clots. Ooh, it's a nosebleed. Epistaxis and petechiae with a normal platelet count. Platelet type of bleeding with a normal platelet count. Ooh, that looks to be von Willebrand's disease. The PTT is normal. Well, that goes sort of against von Willebrand's, but you can have a normal PTT in half of people with von Willebrand's. The platelets don't stick to the blood vessel wall. Oh! Ding, 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 ding. Giant platelets. Giant platelets, and it's a receptor defect. Giant platelets. Giant platelets, and it's a receptor defect, is Bernard-Soulier. Soufflé. Giant platelets with your soufflé. Bernard-Soulier. Sorry, it's sexual in French. Von Willebrand's disease is not a defect in the receptor. Next, Glanzmann's thrombasthenia is it doesn't have giant platelets. Heparin overdose would give an elevation of the PTT. Heparin overdose also doesn't present predominantly with epistaxis and petechiae. Heparin overdose would present with signs of clotting factor type bleeding. Epistaxis and petechiae with a normal platelet count. I've heard that before. That's a platelet type of bleeding. Epistaxis, petechiae, gingiva, gums, skin. The PTT is normal. Platelets don't stick to each other. Ooh, to be. A man's glands want to be aggregated with you. Glands man's or man's glands? Man's glands wants to be aggregated with you. Glanzmann's thrombasthenia. Now, most important K for platelets from here, ABL. Ooh, there's no matching that you need. Platelets? Well, you don't have to match platelets for anything. Platelets are platelets. Well, it turns out that if you don't HLA type them, not ABO, because there's no ABO antigens on platelets, but they do have some HLA receptors. So let's be precise about this. You can give the platelets without HLA typing, but they won't rise. The platelet count won't rise as much. You can give the platelets without HLA matching them, but the platelet count won't rise as much. The platelet count rises more. The platelet count rises more if you HLA type them. So the platelet count rises more if you HLA type the platelets. Other than that, the antibodies can attack the donor platelets more. So in other words, you can give the platelets because it's not the same thing as like the hemolysis of ABO incompatibility, but you don't have as effective a rise in platelets unless you HLA type them. The other thing is Glanzmann's and Bernard-Soulier are reasons to need platelet transfusion repetitively through your whole life. So you don't want to alloimmunize. What about for acute bleeding? Oh, what acute bleeding? When you have fresh frozen plasma, that's clotting factors. Fresh frozen plasma is all clotting factors except factor VIII and except von Willebrand's factor. Factor VIII and von Willebrand's factor are underneath the endothelial cell. So in donor blood, you see, FFP is sort of a byproduct of donor blood. You give a 500 milliliter blood donation, and then you use the red cells. You use the packed red cells. You use the packed red cells, and the FFP is either made into other things or thrown away. It's a byproduct. So fresh frozen plasma doesn't have anything to do with platelets. Epsilon aminocaproic acid inhibits fibrinolysis, so it keeps the fibrin intact. Steroids don't do anything for the platelets there. Cryoprecipitate is mostly fibrinogen. Why would fibrinogen help? And the answer is it wouldn't. Well, why does epsilon aminocaproic acid help? Well, platelets stick to each other. One by von Willebrand's factor. What's the other thing that holds platelets to each other and to endothelial lining? The other thing that holds platelets to each other and to the endothelial lining is fibrin. Platelets are attached to each other and to the endothelial lining by fibrin and by von Willebrand's factor. So if your von Willebrand's factor, the receptor for the von Willebrand factor is not working so well, we try and make the fibrin sticky more. The person has a motor vehicle act. Do we get that one here? Epsilon aminocaproic acid inhibits fibrinolysis. It's not a really strong drug. But you have two choices here. You either transfuse platelets or you use epsilon aminocaproic acid to inhibit the breakdown of the fibrin, because fibrin also helps platelets stick with each other. A person has a motor vehicle accident, gets 12 units of transfusion, and the 12 units of transfusion starts oozing. Why? Well, you could say maybe you forgot to give calcium. I forgot to give calcium because the citrate anticoagulant now is starting to bind up all my calcium in the body, so I'm getting anticoagulated. Oh! Why? Well, how many units of blood does your whole body have? Do you ever think about it? Your whole body, if you're large, has about 10 or 12 units. Do blood donations, does packed cells have platelets in it? Not much. Not much. Your blood donation as packed cells has platelets, doesn't have much in the way of platelets in it. Doesn't have much in the way of platelets. So what ends up happening if you dilute it out, if you replace the entire body's blood volume, okay, if you replace the entire body's blood volume, it dilutes out the platelets. Dilutes out the platelets because you've essentially replaced the total body volume of blood. Several children from anemia have heavy periods. After blood transfusion, she has purpura, petechiae, platelets drop. What do you call it when you have post-transfusion purpura? Happens more in women who've been pregnant. In women who've been pregnant. Do you know what the name of post-transfusion purpura is called? Post-transfusion purpura is also known as post-transfusion purpura. What a great name! Now you know exactly what it is. You're sensitized against platelets. And so what do? You actually use intravenous immunoglobulin, and it helps block your attack against your own platelets. You use intravenous immunoglobulin, and helps block your attack against your own platelets. Wow! Did you know that when you have a person who has this platelet count, but it's 90,000, it's not bad. It's not bad. Gestational thrombocytopenia, are you kidding? You mean just by being pregnant, I can have a low platelet count? Yes, isn't that amazing? Just by being pregnant, you can have a low platelet count. Just pregnancy alone. And now, why don't you have to do anything about it? Because it's not HELP syndrome. The normal transaminase is not HELP syndrome. There's not hemolysis. It's not HELP syndrome. It's not HELP syndrome. It's just low platelets and not life-threatening. No hemolysis, no elevated liver function tests. So it just sort of dilutes out. Remember, pregnant women get really big and juicy at 50% increase in plasma volume. So it dilutes it out. Which anticoagulant causes hyperkalemia? Warfarin. I never heard of that. Remember, if you've never heard of it, it can't be there, right? No, warfarin. Heparin. Well, the truth is I have no idea. I never thought about it. Glycoprotein 2B3 inhibitors. What are they? Are there those? Oh, remember? They're in cardiology. Abscimab, eptifibatide, abscimab, eptifibatide, tirofiban, abscimab, eptifibatide, tirofiban. NOACs, which is apixaban, edoxaban, rivaroxaban, apixaban, rivaroxaban, edoxaban, apixaban, rivaroxaban, edoxaban. No, NOACs don't do it. Did you know that heparin causes hyperkalemia? Yeah, we think it has to do with the fact that it inhibits the adrenal gland some. Heparin seems to inhibit the adrenal gland some. Wow, I didn't know that. Well, that's why we're studying for boards. Isn't that fantastic? Yes, it's a nose. It's a nose. I strongly suspect an epistaxis question is coming on. I strongly suspect... Oh, look at that. It's epistaxis. Recurrent episodes are hard to control. The spleen is not palpable, meaning it's not hypersplenism. And the platelet counts are low. So, by definition, a ITP is isolated thrombocytopenia. By definition, it's low platelets in the absence of any other identifiable etiology, in the absence of hypersplenism. It's low platelets in the absence of any other identifiable etiology. It's low platelets in the absence of any other identifiable etiology. Epistaxis, hard to control. Okay, so what do you feel when people have platelets that are above 50,000? Nothing. When people have platelets that are above 50,000, there's no symptoms above 50,000. And unless you're going to do surgery or you're actively bleeding, you shouldn't transfuse above 50,000. Now, in general, you shouldn't even feel 40 or 30,000. Spontaneous bleeding generally starts below 20, 30,000. So in most patients, unless you're bleeding or going to have surgery, don't do anything with they're above 50,000. And symptoms, generally you can lose everything down to, like I said, 10, 20,000 usually, 10 or 20,000. And when you do have here where you have some symptoms at 27,000, it's relatively minor bleeding like epistaxis. You don't bleed into your brain much at 27,000 platelets. So there is no test to prove somebody's got ITP. There's no test. You can sometimes look to make sure the spleen is normal in size, to make sure it's not occult hypersplenism. You might say, well, can't we feel it? Not too well. First of all, American medicine does it. We don't palpate and examine people too well. We get a CAT scan, right? Okay, it's like my ophthalmoscope looks like a CAT scan, head CT. And also, the other thing is, to be fair, besides my snide cynicism, my snarky remarks, is that you have to have a spleen that's 2 to 3 times normal size. You have to have a spleen that's 2 or 3 times normal size before you even begin to feel the thing. So that's why sometimes you have to do a sonogram or a CT to make sure the spleen is a normal size. Antiplatelet antibodies don't help. Now, if there was more than one cell line down, we should do a marrow. Occasionally we have to do a marrow just to be, if we're not certain. But the thing is, it's not something you find in the marrow, it's what you don't find. In other words, you're looking sometimes in the marrow to be sure there's no other infection or cancer in there. But an infection or a cancer shouldn't just be lowering platelet count. It should be lowering the white cells and the red cells too. So there is no specific test for ITP. It's the absence of hypersplenism and the presence of megakaryocytes. The best initial therapy? Mild bleeding, epistaxis, steroids. Well, what happens if you stop the steroids, and it recurs? And you start the steroids and it gets better. And you stop the steroids and it recurs. And you start the steroids and it gets better. You stop the steroids and it recurs. You stop the steroids. The answer is you can do splenectomy. And what's romiplostim and L-trombopag? Romiplostim and L-trombopag are medications that are essentially thrombopoietins. They don't work forever. They don't work forever, but they're thrombopoietins, and you use them for sure if people continue to recur after the spleen is removed. Thrombopoietins that will help raise the platelet count in people with ITP. We used to use vincristine. We don't have to anymore because it's nonspecific. Platelet transfusion is dead last. Platelet transfusion is I have terrible life-threatening bleeding, and I've given all the other treatments, and they're not working, and then I give platelets. Well, why not give platelets first? Because they get consumed. As soon as you put the platelets into the body, they get consumed. They get used up. 37-year-old woman, do you get that point? The platelet transfusions would get consumed up. That's why. Because you see, the problem with ITP is it's much more of a destruction problem, not just not having enough platelets. The body's making plenty of platelets. They just get used up. Oh yeah, dating! 37-year-old woman with epistaxis, hypercells are hard to control. In the last 24 hours, she's got a subdural and epidural. She's got black artery stool and subarachnoid hemorrhage. She has hemoptysis, hematemesis. She also has heavy periods. Plus petechiae. The spleen is not palpable. Well, we got platelet count that is life-threateningly low, man. Life-threatening low with this evil bleeding, life-threatening low platelets, and a PT or PTT are normal antiplatelet antibodies, which you don't need. And the point is, what are you going to do right now for this person's life-threatening bleeding? The fastest way to bring up the platelet count is intravenous immunoglobulin. Intravenous immunoglobulin is the fastest way to bring up the platelet count. Giving platelets does not work because giving platelets, they're just consumed. So when you have life-threatening bleeding and low platelets with ITP, intravenous immunoglobulins. So we have a 17-year-old boy that here is with bloody diarrhea who's got petechiae, low platelets and petechiae, elevated LDH. Uh-oh, something else is there. Elevated LDH. Uh-oh, fragmented cells. Microangiopathic hemolytic anemia, fragmented red cells. But it's not DIC. How do you know it's not DIC? You know it's not DIC because the PT and PTT are normal. That's how you know it's not DIC. It is hemolysis, uremia, low platelets. But we didn't ask you whether it's hemolytic uremic syndrome. We asked you what the etiology is. This is an easy question. E. coli 015787, sure. But the harder question would be this. If E. coli 015787, give that organism a name. I'm tired of saying all those numbers. What's the second most common cause of HUS from an organism? Is Shigella. Now, what if you have HUS not from an organism? What if you have HUS not from an organism? What's the treatment for hemolytic uremic not from an organism? It is eculizumab, the anti-C5 complement drug. Now, what endocrine disorders lower... Now, the big thing for this, if it's not infectious, you can use eculizumab. No matter how low the platelet count is, don't transfuse platelets in people with hemolytic uremic syndromes. What endocrine disorder lowers platelets? Cushing's. High... No. Addison's. Low. Cortisol effect on platelets. No. Thyroid. Diabetes and platelets. Well, you know that you generally need thyroid hormone to have normal cellular division in a lot of things. The same way, if you don't have a normal thyroid, you can't have puberty. No normal thyroid, no pubertal growth spurt with growth hormone, because you need thyroid hormone for growth hormone to release. When is the goal of platelets? 100,000. You can do a colonoscopy on 2,000 platelets. You do skin stuff on 15,000 platelets. GI bleeding, you only need 50,000 platelets. But 100,000 platelets is neurosurgery. Cut my brain. That's when we want 100,000. That's the only time. 100,000 that you go over 50,000 platelets. 22-year-old woman with epistaxis and menorrhagia. Now, menorrhagia, raging menses, coming at you Sunday. Raging menses, only on pay-per-view. Menorrhagia, is that a platelet problem or a factor problem? A platelet problem or a factor problem? The vagina should be treated just as a mouth, and that's why endometrial bleeding is platelet problem. Ooh, this is hard. Lifelong wound healing. Spontaneous abortions, but bleeding. Increased bleeding at birth. Birth, lifelong. PT, PTT are normal. Bleeding time is normal. The bleeding time test that we shouldn't be doing is normal. So this is not a platelet problem, is it? It's not a platelet problem. Because bleeding time would be abnormal in von Willebrand's, Bernard-Soulier, Glanzmann's thrombocythemia. What is it? The initial clotting happens, but there's a delay, and then you bleed. This is really hard. It's factor 13 deficiency, clot stabilizing factor. Of course, clot stabilizing factor. So, when you get cut, the initial plug of bleeding areas is with platelets. But platelets, although they create the clot, would get washed away and destroyed unless they were stabilized with fibrin. So thrombin and fibrin preserve the clot. Because if they weren't preserved with platelets, what would destroy the von Willebrands? What's the destroyer of von Willebrands? ADAMPS 13 is the destroyer of von Willebrand's factor. Now, fibrin would get washed away, because fibrin creates the clot. It would get washed away with plasmin if it weren't preserved up by factor 13. Platelets are the creator. Fibrin is the preserver. Platelets are the creator. Fibrin and von Willebrand's factor are the preserver. ADAMPS 13 is the destroyer. Oh, fibrin is the creator. Factor 13 is the preserver. And plasmin is the destroyer. Oh, Earth is crammed with heaven. And every tree is a burning bush. Those who see it will take their shoes off, and all the rest can at least eat the blueberries. So what do we see in the clotting cascade? Okay, my next book, Mastered the Vedas. Okay, you see Creator, Preserver, Destroyer, Creator, Preserver, Destroyer, Brahma, Vishnu, Shiva. There you go. So how do you tell if the clot stays intact? If the clot stays intact, it's a test you do every day in every screening. It's the euglobulin clot lysis time. You take a clot and you marinate it in like clot tandoori, okay, chicken tikka clot, okay, and you see if the clot will hold the shape by putting in 5 molar urea. And 5 molar urea should not dissolve a normal clot. But unless you have factor 13, it will get destroyed. Factor 13 prevents it from being broken up. Yes, welcome to the American Board of Internal Medicine. It's not step 2 class here, right? You don't need that for step 2. What bleeding if they're serious? If you have factor 13 deficiency, well, there's no factor 13 replacement. So desmopressin releases von Willebrand's factor and factor 8. Factor 8 replacement is for von Willebrand's and factor 8 deficiency for hemophilia. You don't plasma freeze something on here. Cryoprecipitate is giving fibrinogen. Cryoprecipitate is never first for anything. Cryoprecipitate is for DIC. Fresh frozen plasma is what will be given if you don't know what to say and you're replacing non-specific clotting factors. I don't know what to do. Everything except factor 7 and von Willebrand's factor, fresh frozen plasma, to be able to replace factor 13. Remember the factor 13. The reason that the PT and the PTT are normal is factor 13 is not on the clotting cascade. Factor 13 is not on the clotting cascade, so it is normal PT-PTT. And then look at factor 12. Factor 12 gives you an elevated PTT, but no bleeding. Factor 13 gives a normal PTT, but you are bleeding. Euglobulin clot lysis time is a one disease test, factor 13 deficiency. 32-year-old woman epistaxis and bleeding after a surgical procedure. 2 episodes of increased bleeding, but only with trauma, only special circumstances. No spontaneous bleeding, and it can't be, even though there's an elevated PTT, this can't be hemophilia. Elevated PTT, this can't be hemophilia. How come it can't be hemophilia? One, it's the wrong type of bleeding. It is skin bleeding. It's skin bleeding. 2 episodes of increased bleeding after surgery. The other thing is, she's female. Women carry it, but men express it. What? Most of the love poetry and hemophilia. So she is a congenital woman. And as a congenital woman, she cannot have an expression of hemophilia. Because hemophilia is delayed bleeding in a male joint. Delayed bleeding in a male joint. This is elevated PTT, normal PT. Can't be hemophilia. Not showing up at 32, and that'd be delayed bleeding, and not in a woman. Can't be factor 12 deficiency, because factor 12 deficiency elevates the PTT, but there's no bleeding in factor 12 deficiency. This is factor 11 deficiency. And when you have an elevated PTT, and you're trying to tell whether somebody has a deficiency or an inhibitor, a deficiency and inhibitor, a deficiency or inhibitor, when you have an elevated PTT, the first thing to do is, I'm going to mix it up. I'm going to mix it up. Because how deficient do you have to be in a clotting factor before you even begin to get an elevation in the PTT? How deficient? Missing 10%, 30%, 40%, 50%. How deficient do you have to be in a clotting factor before your PTT or PT even begins to elevate? You have to be missing 70 to 80% of clotting factors before your PT or PTT even begin to elevate. So that means if you have a person that had 0% of a clotting factor, and you mix it 50-50 with normal, 100 divided by 2 is equal to 50. So if you had 0% in the patient and you mix it with normal at 100%, it means the level has to come to at least 50%. And since you have to be missing 70 or 80% of clotting factors before your PT or PTT even begin to go up, it means that all deficiencies will correct to normal. That's what you do to tell first. Next, if it corrects to normal, the most accurate test then is to do a specific factor level, get a factor 11 level. Factor 11 deficiency. When you are bleeding for factor 11 deficiency, fresh frozen plasma. Desmopressin is only for hemophilia. And for von Willebrand's disease, cryoprecipitate is mostly fibrinogen. Bad DIC, not getting better with FFP. Steroids don't do anything. No. Patient's on dialysis and is bleeding, having melena. Well, why not Melina? Well, Melina is a nice girl's name. Melina is bad. Melina, she's nice. Some epistaxis. And so what happens, we have no specific lesion, but why is she bleeding? PT, PTT are normal. Hematocrit's low. The issue is end-stage renal disease. Do you know what end-stage renal disease, why it causes you to bleed? End-stage renal disease causes you to bleed because platelets don't work in uremia. Platelets don't work when you're uremic because a platelet has to degranulate. It has to release the contents of its alpha and dense granules to be effective. And you have a platelet that doesn't degranulate. Is a platelet that does not degranulate the same as having a platelet? No. Is a penis that is not erect the same as having a penis? No. So this is, in uremia, what you get is erectile dysfunction of the platelets. They don't degranulate. Of course they don't degranulate. They don't want to work. They're up. Would you want to work if you were buried up to your chin in urine? You wouldn't want to work either. So platelets don't degranulate in a uremic environment. And how do you give those platelets a little squeeze? What is platelet Viagra? Platelet Viagra is desmopressin. Von Willebrand's factor gives a little kick in the booty and it degranulates. Another exciting section of the internal medicine class. Oh, I'm so happy I don't know what to do with myself.